Hello everyone, Dynamic Retinoscopy, which is the third lecture for NV 2623 Primary Care Optometry 3. Before I start the lecture of the Dynamic Retinoscopy, you need to understand about the accommodation. In accommodation, you need to know about the accommodative stimulus, accommodative demand, and also accommodative response. First of all, we talk about the accommodative stimulus, which is defined by the near target stimulus. And because of depth of focus and depth of field, the accommodative response is generally less than the accommodative stimulus. And normally, near point located around 10 to 17 centimeter and can be until 40 centimeter. But beyond the near target of 40 centimeter, there is no more accommodative stimulus. Now let's check about the accommodative demand, which is accommodative demand is provided by the target distance as well as the refractive error. And we have either under minus or over minus. First of all, we talk about the over minus, or we also can call it as under plus, which is patient has extra accommodative demand required to see target clearly. But for the under minus, patient does not have to accommodate as much to see the target clearly. Now, the last one is accommodative response. Accommodative response is a measure of the actual accommodation that is present, which is if your accommodative system likes to hang out. There is three types of the accommodative response. First, right on the target, which is accommodative response equals to the stimulus. The second one, in front of the target, which is accommodative response more than accommodative stimulus, and we also can call it as the accommodative lead. And the third one, which is behind the target, which is accommodative response less than the accommodative stimulus, or we also can call it as a accommodative lag. Dynamic retinoscopy is always referred to the lag and also the lead of accommodation. What is the difference between lag and also lead of accommodation? Lag of accommodation is the dioptric value in which the accommodative stimulus exceeds the accommodative response. Or in other words, like I said, accommodative response is less than accommodative stimulus. The neural point is situated further from the eyes than is the retinoscopic target. Lead of accommodation is the amount by which the accommodative response of the eye is greater than the dioptric stimulus to accommodation. Or in other words, accommodative response is more than accommodative stimulus. And it also can occur as a result of a spasm of accommodation. Dynamic retinoscopy, the method by which you determine the patient's near point, which is location in space that a patient's eyes are focused when fixating a near target. This condition also refers as an accommodative response. It also can be defined the patient accommodative posture, which is most of the patient is under accommodate for the near target. However, there is a patient which will have over accommodate with the near target. Dynamic retinoscopy is a primary use to confirm suspected cases of vision and or accommodative dysfunction. It also can be used to determine whether a patient is wearing over or under-corrected spectacle. Any eye examination in which a patient has near complaint or if you are suspect accommodative problems such as latent hyperopia or other accommodative spasm. Normally, in these cases, patient will have a symptom of near blur, astinopia, diplopia, and also headache. Dynamic retinoscopy also can be used for all pediatric assessment and some sort of PV assessment. Dynamic retinoscopy also reveals the stability of the degree of fluctuation of the accommodative system. It can be stable if the accommodation is probably not fluctuating so much, or if the results seem to fluctuate, you may be dealing with accommodative spasm. So you need to know to interpret the result of the dynamic retinoscopy. And accommodation must be engaged or functioning in order to determine near point when you are doing the dynamic retinoscopy procedures. It is different from the static retinoscopy where the accommodation must be relaxed in order to determine the far point. What is the difference between dynamic retinoscopy and static retinoscopy? In static retinoscopy, the refractive state is determined while subject fixates an object at a distance of 6 meters. This is to make sure that accommodation is relaxed. However, in dynamic retinoscopy, refractive state is determined while subject fixates at near object or target, and normally at or near the plane of the retinoscope. And in the dynamic retinoscopy, accommodation fully in play or active. In static retinoscopy, working distal lens is used, which is added or subtract from the objective finding. And however, in dynamic retinoscopy, there is no influence of the working distal lens. In static retinoscopy, it only can determine the emetropia or emetropia. However, in dynamic retinoscopy, it can determine the lack of accommodation and also the refractive error. What do you get from the dynamic retinoscopy? From the dynamic retinoscopy, we can identify the lack of accommodation. From here, we can determine the relationship between the vision and accommodation. This is very important in binocular vision case. From the dynamic retinoscopy also, we can identify the tentative addition to the patient. And we also can determine the final refractive error using the static retinoscopy. Dynamic retinoscopy techniques. There is a lot of techniques in dynamic retinoscopy. In this lecture, I've only discussed 8 from all the techniques, which is I will cover the cross method, Tate's methods, Knox method, low neutral and high neutral methods, Bell retinoscopy, MEM retinoscopy, Mohindra retinoscopy, and also the last one, which is radical retinoscopy. The cross method. The pioneer in the field of dynamic retinoscopy, which is he also called it as dynamic skimetry. In the cross method, he recommends that his procedure as an alternative to psychoptic refraction in latent hyperopia and also for determining the correction in case of astigmatism, presbyopia, and subnormal accommodation in young patients. The cross method procedure. The cross procedure was to start with the static retinoscopy finding after removal of the working distant lenses, therefore working with motion, and to add plus lenses to the point just beyond the neutral point until a reversal occur. In his discussion of latent hyperopia, which he referred to a ciliary spasm, he reasoned that although a patient with ciliary spasm is unlikely to fully relax accommodation when refracted at 6 meters without a psychophagy, when the same patient is refracted by dynamic retinoscopy, the increased muscular effort required will bring about a more normal relationship between accommodation and convergence, bring out the full amount of the hyperopia. Cross recommend prescribing the full amount of plus found in the dynamic retinoscopy finding. However, normally, patients will not persist in wearing spectacles or contact lens with the RX greater flux. Shared method. This is the second technique in dynamic retinoscopy. Shared recommend plus lens power was added until neutral motion is seen. However, this is different or contradicts with the cross method. In the cross method, plus lens power was added until a reversal motion is obtained. And according to the shared, this is actually measuring the negative relative accommodation. It was Shared who introduced the concept of lack of accommodation. He defined this as a lack of accommodation behind convergence occurring during dynamic retinoscopy. He considered this lack of accommodation to be a normal condition, saying that an emmetropic patient possessing a normal amplitude of accommodation and normal amplitude of functional reserve will require from 0.5 to 0.75 diopter of plus lens power for neutrality to be obtained in dynamic retinoscopy. So the normal range of the lag is actually from plus 0.5 to plus 0.75 diopter. Shared method procedure. In performing dynamic retinoscopy, should select the patient's usual reading distance as his working distance. Adding plus lens power to the distant retinoscopy lenses until neutrality occurs. Immediately stop adding plus lens once you obtain the neutral motion. Should believe that the normal lack of accommodation was 0.5 diopter or slightly more. Because of that, he routinely subtract 0.5 diopter from the dynamic finding. This is one example how to calculate the lack of accommodation from the shared method. First of all, you need to know the dynamic finding. The dynamic finding can be calculated using the sphere power of the dynamic retinoscopy and static retinoscopy. The different sphere power between dynamic retinoscopy and static retinoscopy, we call it as dynamic finding. The dynamic finding will be subtracted with the 0.5 diopter. So for this case, the lack of accommodation is plus 0.75 diopter. Tate's method. This is the third technique in the dynamic retinoscopy. He used working distance at 33 cm. There is a different value of lag accommodation compared to the shared method. Procedure. He found each patient with a considerable amount of plus lens power and then approached the neutrality point by reducing plus lens power. Using these fogging methods, he found an average of approximately 1.5 diopter more than he found with the search system. Next is the knots method. Using the knots method, the patient reads the letters around the aperture of a near point cut while the examiner performs retinoscopy through the aperture. Instead of using lenses, the retinoscope is moved backward, which is towards to the examiner, until neutrality is achieved. The distance from the retinoscope mirror at neutrality is converted to the diopters, and the lack of accommodation is determined by comparing this dioptric power to the version of light arriving the spectacle plane from the near point cut. For example, if the distance from the near point cut to the spectacle plane is 40 cm, which is equivalent to 2.0 diopter, and the distance from the retinoscope to the spectacle plane is 50 cm, which is equivalent to 2.5 diopter, so the lack of accommodation, which is 0.5 diopter. Low neutral and high neutral methods. It is similar to combination of cross method and shirt method, whereas adding plus lens is referring to low neutral methods and reducing plus lens is referring to high neutral method. For more information, please read Gross-Venor textbook. Bell retinoscopy was named for a small shiny bell dangling from a string that was used as a fixation target. However, in practice, the bell has generally been replaced with a wolf wand, a shiny gold or silver half-inch diameter metal ball mounted on the end of a rod. The distance between patient and examiner is 50 centimeters. And in this technique, the target is moved but the examiner is constant. There is no lens is used in this technique. The measuring of the lack of accommodation as a linear, which is moving target. Bell retinoscopy procedure. As I mentioned, in the bell retinoscopy procedure, you will use small bell or C-ball in front of the examiner forehead. And retinoscopy is done at 50 cm binocularly with the distance correction. You will see with motion. Ask the patient to focus at the bell or C-ball. Move slowly the bell or C-ball towards spectacle plane until neutral reflex is obtained. Then, again, move slowly towards the spectacle plane until against motion is obtained, marked as a first distance. Then change the distance away from the spectacle plane until with motion is obtained and marks the distance with the with motion. Record both of the distance. Convert the distance into dioptric. Then finally calculate the lack of accommodation, which is the difference between dioptric first power and release power. Monocular estimate method or MEM retinoscopy. This technique can determine the lack or lack of accommodation. The normal range of MEM retinoscopy is plus 0.25 diopter to 0.75 diopter. The fixation target is white cut with 1/2 inch hole, and the fixation can be letter, words, or picture. When you are doing the MEM retinoscopy, you need to ask your patient to wear his or her distance correction. This is some of example of the fixation target, which is, as I mentioned, it can be letters, words, or picture. MEM retinoscopy procedures. First of all, patient need to wear his or her own distance correction. Then, ask the patient to see the MEM card which is attached with the retinoscope. The working distance for the retinoscopy is 40 cm from the patient. Ask the patient to read the letter or words on the MEM card loudly. Quickly, retinoscopy is done on both eyes simultaneously, which with motion is present. Add plus lens until you obtain the neutral motion. The retinoscopy is also done on both meridians for one eye. And record the sphere power that you need to neutral the patient eye. So in MEM retinoscopy technique, you neutralize the reflex of the eye while the patient accommodates to fixate a target at near, which is usually at 40 cm. You will add plus lenses when you see with motion, and you will add minus lenses if you see against motion. Mahindra retinoscopy, also known as near monocular retinoscopy. We can estimate the refractive error using this technique. I always use this technique to estimate the refractive error among infants and children. The retinoscopy technique in the Mahindra is done in dark room and at 50 cm. As I mentioned, this technique is done at 50 cm in dark room. You need to occlude the untested eye. First of all, ask the patient to focus on the light from the retinoscopy. For baby and children, use bell sound to attract the attention. Retinoscopy is done on both meridians using sphere lens or lens wrap. You need to repeat the same procedure on the other eye. Transpose the sphere power on both meridians to the sphere seal. And you need to add minus 1.25 diopter to the spherical component. Finally, record the finding. Radical retinoscopy, which is the last technique in dynamic retinoscopy. You can use this technique when you have patients with small pupil, cataract, and also opacity of the ocular media. When you see dull and faint red reflex at 50 and 67 cm with the normal retinoscopy technique, you also can proceed to the radical retinoscopy. You need to move closer around 10 to 20 cm until the red reflex can be obtained. Make sure you need to maintain the same distance because with the closer distance can cause large error in the retinoscopy technique. This is one example of the calculation for the radical retinoscopy technique. Let's say if the distance is 20 cm, it actually equivalents to the plus 5 diopter. Subtract the refractive error from the refractor. For example, if minus 1 diopter for the sphere, the actual refractive error will be minus 6 diopter. How about if you use working distance at 10 cm? Please calculate when you use with the working distance 10 cm. This is comparison of dynamic retinoscopy between two examiners. For further information, you can read from the Gross-Perner textbook. As I mentioned, in dynamic retinoscopy, we have a lot of technique, And I have mentioned about 8 techniques in dynamic retinoscopy. However, for your information, in our clinic or in our practice, we are practicing 3 techniques only, which is Bell, MEN, and Mohindra retinoscopy. Make sure you know well these 3 techniques. So, this is the last slide for this lecture. Please, I want you to go and find out. Do some analysis about the different technique of the dynamic retinoscopy according to this subtopic. Thank you so much. Any inquiry or question you can ask in discussion in iFolio. Thank you again.